Thank you, Dr. Feingold, for your talk. I'd like to introduce Dr. Rod Ghassemzadeh. Rod is an assistant professor of critical care medicine. In pediatrics, he's assistant program director for the pediatric critical care medicine and is attending in our cardiac critical care unit. He will be talking on the CICU management and tips post-heart and liver transplant.
Thank you to the organizing committee. It's an honor to speak amongst all these experts in the field. My job will be to discuss the CICU management, which in reality takes all the wonderful work that all the experts have already spoken on and organize them into a play that ultimately gets us to the goal line, which is getting these patients from a failing Fontan into a transplant, whether that be a liver, a heart transplant, or a combined heart-liver transplant. What it really requires is an organization of the entire team to really mobilize all of our advanced therapies to get them there. Strangely enough, when I looked up a picture of a playbook, it was the Pittsburgh Steelers running game against the Baltimore Ravens. It's an American football team here, so I hope I'm not divulging city secrets. So here's the team, the entire congenital heart team, including our interventional docs, adult congenital docs, electrophysiologists, interventional proceduralists, as well as our entire subspecialty team. As we know, these patients have a lifetime of success and complications, all of which is managed by a multidisciplinary team. So engaging them in the process from the beginning is vital to success. So again, we've spoken about this in a variety of different presentations about the level of dysfunction these patients have coming in, but specifically from a CICU standpoint, dealing with the Fontan pathway dysfunction, which leads to symptomatic chronic fluid overload, effusions, ascites, and very severe cyanosis. Ultimately, we manage that with a high degree of diuretics, and milrinone, as Dr. Zinn mentioned earlier, is our primary vasoactive to help treat Fontan pathway dysfunction. Although we are limited in this setting, too much diuresis, and we get rid of the passive movement of fluid and blood through the Fontan pathway, so we can't over-diurese and we can't under-diurese because we can't allow the fluid to cause significant multi-organ dysfunction. And then from a ventricular dysfunction standpoint, we usually use inotropes and other vasoactives that better tighten up the peripheral vasculature so that we can increase the SVR and get blood to the organs that it needs to go to. But again, in the setting of ventricular dysfunction, potential AV valve regurgitation, we may be hindered in that process. We are plagued by recurrent arrhythmias in these patients of all sorts of varieties, ranging from symptomatic bradycardia to malignant tachycardia. And unfortunately, at this stage of the game, any therapy to help treat that can potentially worsen ventricular dysfunction, worsen end organ dysfunction, such as amiodarone, procainamide, things like this that ultimately cause more problems than they help. So we oftentimes get stuck between a rock and a hard place. Lymphatic dysfunction plays a big part in, again, chronic fluid overload, plastic bronchitis. This is where our pulmonary team helps us out with novel therapies to help prevent respiratory failure related to that, as well as refractory PLE that affects our drug metabolism, our maintenance of albumin, our ability to maintain good nutrition in these patients, which we'll talk about soon is vital for them. And then extracardiac dysfunction, obviously the liver is affected. You may have varying degrees of cirrhosis, unclear how much is reversible, which affects synthetic liver function, drug metabolism, and excretory function. You have renal dysfunction or chronic renal failure, and oftentimes the interplay of the cardiac renal syndrome ultimately decreases the effectiveness of your diuretics and hinders your ability to maintain the patient forward towards transplant. In addition to the dysfunctions I've already mentioned, oftentimes these patients already come in with obstructive respiratory disease, endocrinopathies, adrenal insufficiency, thyroid disorders from prior medication exposures or genetic abnormalities. The neurocognitive changes are ongoing. Even just being in the ICU alone can cause long-term neurocognitive changes that may or may not be reversible. And thromboembolic complications and secondary erythrocytosis can be very troublesome, especially in the setting of needing to maintain vascular access, prevent strokes, and if a patient is on mechanical support, ensuring that it runs smoothly without any issues. And protein-losing enteropathy we already mentioned. Thankfully, in the cardiac ICU, pregnancy and sexual dysfunction don't come up very frequently. So this is a chest x-ray for one of the patients that we saw at our institution that came in for heart transplantation. Obviously, based on this x-ray, you can see a significant left pleural effusion, diaphragmatic dysfunction, and infiltrative disease, pulmonary parenchymal disease that's spread throughout the lungs. This is the starting point. So you can imagine the consultation and the anticipatory guidance given to the family is to expect that lung disease is going to be part of their long-term recovery and will certainly be a factor and a risk moving into surgery. Vascular access, the importance of which knowing and understanding what is open, what's available, and where you're going to access in order to provide advanced therapies if they need to. We are very blessed at Pittsburgh to have a very dedicated team to all aspects of advanced extracorporeal therapies, including obtaining vascular access, running ECMO or other mechanical support, our CRT team, as well as a plasmapheresis team, all of which we use very frequently and in interplay, oftentimes simultaneous, which helps us with limiting the amount of extra access we need, but sometimes we have no choice but to employ those strategies. As was previously mentioned, the vasoactives that we tend to use most frequently are milrinone, oftentimes upgrading to epinephrine and dobutamine, and oftentimes we may introduce vasopressin as well, given its effects to help reduce pulmonary pressures and renal pressures, counter to what it does to the rest of your SVR, and that helps us with maintaining blood pressure as well as ensuring that our pulmonary pressures are low and that we can maintain some diuresis. And we utilize all forms of diuretics, and you have to really use a multimodal approach given the lack of response, the usual response to diuretics. And oftentimes, medical management is not sufficient, so upgrading to the mechanical support that Dr. Zinn had mentioned earlier is necessary. And creativity is the name of the game in this situation. Understanding what the preoperative or pre-procedural pre-VAD anatomy is, how complicated is it going to be to go in, what's the patient's nutritional status, and how successful are you going to be to maintain the cannulas and the skin sites, as well as how will this mechanical implantation affect the future surgery of heart or combined heart-liver transplant. This is an X-ray of a patient that we supported with Impella for several weeks as a bridge to transplant. And really, this patient was sort of at the edge prior to collapse, and Impella really helped us get through the last few weeks prior to transplant. Nutrition, 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 often forgotten, one of the most important aspects of taking care of these patients. Unfortunately, it's not uncommon to see cannula sites that are either infected or broken down because you dropped the ball on the nutrition. Overfeeding, CO2 burden, caloric deficits, immunosuppression, micronutrient imbalance, protein deficits, all affecting wound healing, development, infection, resource utilization, mortality, ICU stay, prolonged ventilation, and muscle strength and function, which ultimately, if you're successful in getting transplantation completed, this will be what will drive the patient out of the ICU. And if you can't get them there, then you'll be stuck. So the multimodal assessment is what, as ICU doctors, we ensure happens alongside the medical components. The clinical status, fluid status, anatomic lesions and considerations, hemodynamics, evaluation with the heart failure team, evaluating the modifiable risk factors such as collaterals, nutrition, physical conditioning, organ-specific comorbidities, and ensuring that we have the appropriate specialties have their eye on those organs, as well as the psychological and neurocognitive considerations. And as well as limiting sensitization, limiting blood products, and having protocols that dictate how you can limit blood products as much as possible, because sensitization can even happen in the brief period of time that you're waiting, hopefully, in the CICU for transplant. Having some kind of protocol for understanding which patients will go for combined heart-liver or just heart is vital. I think nowadays, especially that heart-liver is becoming more common, it's clear that some patients do fine just with a heart transplant. And adding the extra wait time, given the lack of resources, a lack of availability of multiple organs, we want to make sure that we utilize them appropriately. So understanding which patients should go for just heart, which patients should go for heart-liver. And choosing the right one ensures success. This was a study done, I believe, by the group in Columbia, in New York, that looked at pre- and post-operative factors and outcomes for patients who receive heart transplant versus combined heart-liver transplant. And oftentimes, maybe not unexpectedly, the heart transplant-only recipients had a shorter time from Fontan completion, higher hemoglobin level, less diuretics at presentation, less likely to be transplanted in the recent decade. Combined heart-liver transplant recipients, longer time from the Fontan, lower hemoglobin, more diuretics at presentation, more likely to be transplanted in the recent decade. And at transplant, the heart transplant recipients, not unsurprisingly, have a shorter cardiopulmonary bypass time, whereas the combined heart-liver transplants have a longer cardiopulmonary bypass time. There are other mentions in this study about shorter ICU stay, hospital stay versus longer, but there's a recent study at Stanford that may conflict with that, so I'll discuss that as well. And ultimately, what the two studies do share is that the outcomes are about the same, especially improved in the combined heart-liver if you have cirrhosis, especially in their FALD scoring greater than 2. Understanding preoperative risk factors listed here. I think all of these were mentioned in prior conversations. Third tip I have is protocolization, ensuring that you know how to balance between fluid management and blood pressure management, both organs which require totally different things post-transplant. For heart transplantation, we usually limit fluid, limit the afterload and blood pressure, whereas in the liver transplant, you want to maximize fluid and maximize mean arterial pressure in order to ensure that the liver gets adequate blood flow. So it's the interplay between these two where you have to know where to find the balance. And having both teams at bedside during rounds is vital in that process. The inter-op strategy for how each organ is supported certainly is not something that we control in the ICU, but may affect the post-operative management. It was interesting how every different center has a different strategy for supporting each organ, and some doing en bloc, some doing sequential, some choosing to do veno-venous bypass of the liver, some choosing to do total cardiopulmonary bypass for both, and some choosing to support via ECMO throughout post-bypass period. Post-operative bleeding is inevitable and annoying. So ensuring that you have covered treating coagulopathy, ensuring that you do not have hypothermia, treating with bicarbonate for metabolic acidosis, and optimizing your organ function to ensure that you can stop the bleeding, because unfortunately, especially in the setting of mechanical support, bleeding will be there. And ensuring that you have liaised with your blood bank to have a protocol in place so that when there is bleeding, especially when it gets more into massive bleeding stage, you have a protocol in place. We have found whole blood and medical management, advanced medical management of bleeding post bypass to be extremely helpful. it was incredible. One of our patients just bleeding, and then after 1 or 2 units of whole blood, bleeding stopped quite a bit. But engaging with your surgical colleagues to make sure all bleeders and leftover lesions are addressed, because no amount of medical management will fix that. And using diagnostics such as TAG and ROTEM, which we use at our institution, to identify the problem so that you're not providing unnecessary blood products. Managing fluid overload is really what's going to keep them in the acute range post-operatively. It will affect lung function, kidney function, abdominal function. So we at Pittsburgh use an aggressive strategy of getting fluid off as soon as possible, whether they're on mechanical support and we can utilize the CRT through the mechanical support system, or ensuring that our surgeons or interventional team can give us long-term dialysis catheters so that we can just keep the train rolling on fluid removal and ensure that their lungs don't receive any extraneous damage from lack of fluid removal. Nutrition rehabilitation, I already mentioned the importance of that. That continues post-operatively, being mindful that these patients likely had significant chylous drainage and protein loss beforehand, so they're at risk for infection, at risk for chronic chylous drainage, protein loss. So ensuring that when you do start feeds, you start with low fat or no fat formulas. Consultation with the rehab team early, and considering early trach and G-tube to help with mobilization, limiting sedation, and getting them out of the ICU as soon as possible. Outcomes, this has been reviewed, so I'll just quickly breeze through that, at least in the most recent data from Stanford, in a retrospective study, so not totally similar groups, but the outcomes for heart transplant and heart liver transplant were very similar with similar complications. The only post-operative item that was different between the two groups was the ischemic time, which was obviously longer in the heart liver transplant patients. There was freedom for rejection in the heart liver transplant patients longer than the heart transplant patients, but given the grouping and number of patients in each group, that data has to be taken for what it is. And it's thought that the immunological benefit from a new liver helps with that decrease in rejection in that group. And given that my other hat in the ICU is quality improvement, I want to highlight the fact that having mechanisms in place to ensure that there's good team communication, resuscitation action plans in place, and making sure that every team understands what your targets are, what your expectations are given a patient's preoperative risk factors and postoperative risk factors, is vital to ensure your team moves forward and a patient doesn't get stuck in the ICU cycle where they receive more and more therapies and have a tough time leaving. I couldn't think of 10 tips, so the 10th tip is to thank the organizing committee and my ICU and Heart Institute colleagues for allowing me to share our institution's experience. Thank you.